So we were saying that the maximum breathing capacity is 150 175 liter per minute. The estimate of max ventilation available to meet increased physiological demand. So we assess the ability of the body to increase ventilation when it's needed. زي مثلا في حالة الاكسرسايز مثلا measured for 12 seconds. قبل قلنا انه الاسبيروميتر when we use spirometer for measuring the force vital capacity we measure for 4 seconds. هنا maximum breathing capacity it's measured for 12 seconds and extrapolated for 1 minute. يعني بنشيل 12 seconds دي بنعمل لها extrapolation، يعني بنعمل لها بنرسمها على دقيقة كاملة، بنسقطها على دقيقة. So the maximum ventilation equal the force expiratory volume 1 times 35. الماكسيموم maximum breathing capacity and the maximum ventilation are altered by airway resistance. So if there is an increased airway resistance, they decrease, which is the elastic property. Elasticity means the repulsion of the structure، يعني زي الحاجة المطاط كده بتجرها بتقوم بترجع، يحصل لها recoil، elastic recoil. Also it's altered by muscle strength because previously we mentioned that for you to breathe maximally you need a normal muscle strength. Learning and coordination، maybe the patient have mental retardation so he or she can't follow instructions. Motivations, the desire of the patient to follow orders, so cooperation of the patient. So these are the 4 things that may indicate why the maximum breathing capacity or the minute ventilation is reduced if we monitor it using pulmonary function test. If we excluded abnormal mentality, mental retardation, and the patient is smart and understanding what we are saying, and we excluded the lack of motivation and when we pointed out that the patient is cooperating and they were normal muscle strengths, then it's an airway problem. So respiratory muscle strengths evaluated by maximum inspiratory and expiratory efforts. The pressure is generated against the occluded airway. So we are measuring a static pressure. The airway are occluded. Measured when inspiratory muscles are at their optimal length at the residual volume. So inspiration and expiration. And at this residual volume, we measure the maximum static inspiratory pressure, which is PI max, which is 125 centimeter water mercury minus 125 centimeter water pressure. Sorry. So the clinical significance of this, if the maximum inspiratory pressure, static inspiratory pressure, is less than 25, there is inability to take a deep breath. And the maximum inspiratory pressure is important for achieving vital capacity, for filling the airways, and it's one of the indicative of neuromuscular junction problems. So we are measuring the maximum respiratory pressure to assess the muscle power. the respiratory muscle strengths. Okay. Evaluate the inspiratory and expiratory efforts, and it's measured when inspiratory muscles at their optimal lengths, residual volume, and it's 125 centimeter water, and if it's less than 25, inability to take deep breaths, neuromuscular junction problem, or drugs. The maximum expiratory pressure measured after total inspiration to total lung capacity. So the expiratory pressure is measured during maximal inspiration, and the inspiratory pressure is measured during relaxed expiration or maximal expiration. Sorry, maximal expiration you measure the inspiratory pressure. Maximal inspiration you measure the expiratory pressure. Opposite. Normal value is 200 centimeter water, and if less than 40, impaired cough ability. So basically, there are two differences between them. The maximum PI max, the maximum inspiratory pressure, is measured during maximum expiration. Okay? And the maximum inspiratory pressure normally is 125. And the maximum inspiratory pressure indicate ability to of the muscle to inspire, and if it's less than 25, this is weak, indicate weak muscles, while the maximum expired the maximum expiratory pressure is measured during maximum inspiration. After maximum inspiration during total lung capacity, and is indicative of the function of the respiratory system to maintain normal cough. Normally it's 200 centimeter water, and if it's less than 40, this mean impaired cough reflex. Clear, right? So we can do pulmonary function test before and after giving bronchodilators. ممكن ندي العيان دواء bronchodilator بعديه وقبله نعمل investigation. Obtain a flow volume loop, which means volume function يعني in the expense of time, or volume as a function of time. This is volume flow loop, and we administer bronchodilators. Then we obtain the flow volume loop again at minimum of 15 minutes after administration of bronchodilators. Calculate the percent changes, and then we understand how much bronchodilators affected our results. So we draw the loop, then we give the bronchodilators, then we draw the loop again after 15 minutes. Then we calculate the difference between each values before and after. So we calculate the percent change for the force expiratory volume 1, and we do it by using force expiratory volume 1 post and force expiratory volume 1 pre. We subtract them from each other and divide them by force expiratory volume 1 pre, and we multiply by 10. It's a percentage. ال FEV1 قبل البرونكودايليترز نخصمها من ال FEV1 بعد البرونكودايليترز، بيكون عندنا تشينج. ده اللي هو الفرق، الزياده اللي حصلت بسبب الادمنستريشن اوف برونكودايليترز. الزياده اللي حصلت دي بنقسمها على ال FEV1 بعد هنا قبل البرونكودايليترز بنضربها في 100. يبقى اذا كان مثلا ال FEV1 قبل البرونكودايليترز كان 4 liters or الاف اي في 1 قبل البرونكوديلاترز كان 1.5 liters وادينا برونكوديلاترز بقى 3 بيبقى عندنا شنو؟ بيبقى عندنا 3 minus 1.5 divided by 1.5 multiplied by 100. So 3 minus 1.5 it's 1.5 and divided by 1.5 it's 1. 1 multiplied by 100 is 100. So the increase is 100% after the bronchodilators. This is an example. But what we want to achieve here, what we want to understand is that an increase of 30% or a decrease of 30% after administration of bronchoconstrictor indicate asthma. An increase indicate response to bronchodilators. When we give a bronchoconstrictor, we call it methacholine challenge test. The bronchoconstrictor that we give is acetylcholine agonist. It's called methacholine. So, البرونكوكونستريكتور او الميثاكولين challenge test is used for the diagnosis of asthma. The response of forced expiratory volume 1 and other measures to airflow obstruction to bronchodilators is measured routinely without any consequences as to how this should be performed or interpreted. It's used for identifying untreated asthma. Dramatic improvement of 0.5 liters or more may be seen after only 20 micrograms of inhaled salbutamol. This also improvement after administration of bronchodilator also used as a diagnosis for asthma, as an investigation for diagnosis of asthma. It's called pragmatic diagnosis, the response to treatment diagnose asthma. Other tests, as we mentioned, it's called methacholine challenge test that we induce bronchoconstriction and we measure the reduction in forced expiratory volume. Improvement of 15%, 15% or 0.4 liter, the greater after 2.5 milligram nebulized salbutamol point towards some potential of reversibility. But current guidelines emphasize the need for several days of therapy rather than single laboratory test to assess this potential. So when we give a patient salbutamol nebulized 2.5 milligram, if the patient improved by 0.4 liters or 15%, this means that there is a great potential for reversibility. He can be treated, he can be cured. In COPD, not asthma, both bronchodilator, post expiratory volume 1 and vital capacity vary less than pre-bronchodilator reading and should ideally be used to measure change in lung function over time in longitudinal studies for obstructive disorders. بمعنى في حالة السي او بي دي ما زي الأزمة الريسبونس بيكون أقل بكثير بعدين ما بنستخدمه as a treatment or diagnostic بنستخدمه for research purposes. Bronchial challenges with histamine, methacholine, this is called methacholine challenge test. Cold air or intense exercise بنعرض العيان ل cold air نديه histamine or نديه methacholine which is cholinergic agonist, or we encourage the patient to exercise. All these factors can cause bronchial constriction, and patients with asthma have bronchial hyperreactivity. البرونكاي بتاعتهم شويه كده more sensitive than other people, so they have more bronchoconstriction and they are affected more with these bronchoconstrictors. So we use this to confirm asthma in individuals with normal resting spirometric test. معناه جانا عيان complaining of symptoms of asthma عملنا له pulmonary function test Investigations were normal. What we do, we challenge his bronchial system. We give him histamine, methacholine, expose him to cold air or intense exercise. He will develop more bronchoconstrictions than expected and than normal subjects. Asthmatic subjects react to bronchoconstrictor with a 20% fall in forced expiratory volume. So, if we give the patient a bronchodilator, a response of more than 15% indicate a good response. If we give a patient a challenger, we challenge the patient with bronchoconstrictor. If the fall more than 20%, this is a diagnostic. So here we are talking about alveolar arterial PO2 gradient. We finished the we finished the volumes of the lungs and the capacities of the lungs and the chest. We finished the static and the dynamic, the use of the spirometer and the wide spirometer.
Oh,
So the alveolar arterial PO2 gradient and the diffusion capacity, those are the gas exchange test. The gas distribution test, it's the helium dilution method. We give a patient an air that contains helium and we measure the amount of the helium that diffused to the blood and the amount of the helium that did not. Ventilation perfusion test using imaging, ABG. We will talk about alveolar arterial PO2 gradient and we talk about diffusion capacity. Single press CO2 elimination test is another test, and shunt equation. Those are all the gas exchange tests. Tests for gases are used to assess the normal function of the alveoli because gas exchange is mainly dependent on the alveolar function. Sometimes it's dependent on the inspired oxygen, but if there is a problem with the inspired oxygen, administration of oxygen will normalize the oxygen saturation. So in a setting of hypoxia, patient presented with hypoxia, low oxygen saturation, we give oxygen. If he improved with oxygenation, this means that this patient have hypoventilation. If he did not, this means that the patient have diffusion problem because if you draw it here, it's the alveoli and this is blood vessel. So if there is a low O2 here, I will give O2 from the mouth here, from the nose. I will administer oxygen. If the patient oxygen improved, this means from the start the patient was having a low FiO2. FiO2 means low inspiration O2. If the patient oxygen didn't improve, this means there's a problem with gas diffusion here. The membrane is fibrosed, there is an edema, the lung perfusion is reduced, or anything. Alveolar arterial O2 tension gradient is sensitive indicator to detect regional ventilation perfusion inequality. Normal value in young adult is 8 millimeter Zeva, 8 millimeter mercury, up to 25 millimeter mercury in the 8th decade. This means the alveolar PaO2, alveolar, capital A for alveolar, partial pressure of oxygen in the alveoli subtracted from the partial pressure of oxygen in the arteries. The result must be normally less than 10. It can normally be ranging from 8 to 25. This difference can 25 can only be found in patients above 80 years. But the normal, the maximum normal is 10. So A A difference is 10 maximum. It can be 0. Okay? Abnormally high values at room air is seen in asymptomatic smokers and chronic bronchitis. If a patient is normally having a high A A difference, this means he is having a pathological problem. This occur in patients with emphysema and chronic bronchitis because emphysema is a disease that associated with destruction of the alveoli. So the air cannot be exchanged properly in all alveoli, and the oxygen in the artery, the arterial blood will be decreased. So there will be a huge difference in the room air. So the patients always need to be on oxygen for after a long history of smoking. So the partial pressure of alveolar oxygen equal the partial pressure of inspired oxygen subtracted from partial pressure of arterial CO2. So this means that the partial pressure of alveolar oxygen is dependent on two things: on the inspired oxygen. If you have a normal inspired oxygen, or if you are inspiring oxygen at the room air، حاليا انا وانتم بنتنفس من هواء الغرفه. هواء الغرفه ده فيه 21% oxygen. اوكي، 21% oxygen عنده specific pressure اللي هي 100 more than 100 millimeter زيبا millimeter mercury. This room oxygen is a determinant of alveolar oxygen. لو قل باي شكل من الاشكال الالفيولار oxygen هيقل. اللي بيخلي الهواء اللي بنتنفسه الاكسجين فيه يقل شنو؟ اللي بيخليه يقل مثلا اذا طلعنا من سطح البحر من حله عاليه يبقى الالتيتيود الهاي التيتيود ديكريز ذا انسبايرد اوكسجين، فبالتالي قل الانسبايرد اوكسجين معناه قل الالفيولار اوكسجين. قل الالفيولار اوكسجين معناته قل الديفيوجن اوف اوكسجين، معناته قل الارتيريال اوكسجين. قل الارتيريال اوكسجين معناته اسكيميا. العامل الثاني الارتيريال CO2. If the arterial CO2 increases, the alveolar oxygen decreases because CO2 displaces oxygen. clear؟ النقطة دي مهمة. يبقى أي situation بيخلي الارتيريال carbon dioxide to increase may affect the alveolar oxygen. زي شنو الحاجات اللي بتخلي الارتيريال carbon dioxide to increase؟ هي الهايبوفنتيليشن. زول اللي بيحصل له هايبوفنتيليشن. هايبوفنتيليشن معناها decrease respiratory rate, decrease minute ventilation. decrease minute ventilation معناها increase alveolar CO2 and arterial CO2. decrease arterial CO2 معناها decrease alveolar O2 and decrease arterial O2. The R is a quotient, respiratory quotient, and it's almost equal to 1. So it's insignificant. We can, for exam purposes and for theoretical purposes, we can neglect this value. Diffusion capacity of the lung is measured by measuring carbon monoxide diffusion, defined as the rate at which the gas enter into the blood divided by its driving pressure. بمعنى المعدل اللي بيدخل به الغاز الى الرئه مقسوم بشنو؟ ب الضغط اللي بيدفعه لانه يتحرك من مكان لمكان. يبقى البريشر ديفرنسز هو الدومينيتورز و الريت بتاع الغاز انتري هو النيومينيتور. rate divided by delta pressure. Carbon monoxide taken up is determined by infrared analysis. نحن عشان نعرف الاماونت اوف كربون مونوكسيد taken بنشوفه بالاشعه تحت الحمراء، بس ده موضوع ما يهمني هنا. الديفيوجن اوف كربون مونوكسيد هو بالجاز كيف؟ بالملي بير مينيت بالمليمتر ميركوري، because we are measuring الريت اللي هو مل بير مينيت divided by delta pressure، عشان كده مليمتر ميركوري. We are subtracting the partial pressure of our alveolar CO from the partial pressure of capillary CO. ده الدرايفنج بريشر هنا. طبيعيا في العيان اللي عنده normal respiratory function, so you expect CO carbon monoxide to be zero in the alveoli and to be zero in the capillary in normal situation. To give the patient an prepared air containing carbon monoxide, and he inspire the air, and we measure the carbon monoxide using infrared, and we measure the pressure in the alveoli and in the capillary to determine the driving pressure, to divide it to divide the gas rate entry by the driving pressure. The lung diffusion of oxygen equals the lung diffusion of carbon monoxide multiplied by 1.23. The driving pressure is a gradient between the alveoli and the end capillary tension, as we said. It's following the Fick's law of diffusion. There is something called Fick law of diffusion, and Fick is a scientist who applied this principle